We have applying the forceps, advancing the forceps to the normal cement line and closing up, and finally slacking and pulling out of tooth socket. It's very important steps. So there's some principles of tooth extraction, right? We have three, and first one is that fact that forceps should be applied only on vestibular and oral surfaces of the tooth. Second one, we have a long axis of the tooth, so that long axis of forceps and long axis of tooth should match absolutely 100%. And third one is that we need to avoid applying forceps tips on alveolar ridge and therefore subparietal socket ridge resection. Of course, we have a lot of instruments for that, and the principal instruments are elevators, luxator, forceps, and periotom. Of course, there is a lot of more different shapes of any of the instruments, right? And they could be curved, they could be straight, they could be any that helps you to work properly in the mouth cavity. It's design, it's not interesting, it's not interesting. Yeah, let's talk about complications. So during the operation, we call it tooth extraction as operation, but of course there's a lot of more any things that also called operation. But during the operation of tooth extraction and others, there can be a number of general and local complications related to the peculiarities of the anatomical structure of dental maxillofacial system. Significant pathological changes of the tissues of the maxillofacial area, the presence of concomitant general somatic pathology, as well as iatrogenic nature associated with errors in diagnostics, non-observance of surgery and lack of clinical experience, and others. Analysis collection, individual approach to the patient, careful adherence to surgery techniques, as rule, allow to avoid negative consequences. However, in the event of complication, the dentist is obliged to quickly diagnose it, provide the patient with urgent care, and plan a follow-up treatment. A complication is any event that would not normally occur and which might increase the patient's suffering. The range of potential complications is vast. It includes adverse events occurring locally nearby or distant sites, some things that occur immediately, and others that occur a little later or are greatly delayed. Some are rare and some frequent, some are serious. The indications of adverse events are also determined in a part by the patient's expectations, the reason for surgery, and the manner in which the event is managed once it is recognized. So here you can see the schema of complications that we have during tooth extraction, right? We have local and distant or regional. And of course, by time, it could be immediate, it could be delayed, or it could be late. So locally intermediate, we call fractured crown, root, alveolus, tuberosity. I did yesterday, actually. Yeah, fractured tuberosity by myself. Yeah, caused of my actions, but that was sad. But there is not any other, let's say, there is no any way to avoid that fracture. But still, um, Adjacent tooth, tear, gingiva, velar mucosa, oral internal communication, fractured instrument, injury of regional nerves, and immediate distant complications are crushed or burnt lip, injury to inferior dental or lingual nerves, and lacerated tongue or palate, and of course it could be swallowed of inhaled instruments or tooth, and injury to temporomandible joint. So we have delayed complications in local, we call dry socket, local infection, delayed or secondary hemorrhage, and of course, the worst one is osteonecrosis, right? And distant delayed complication are spread infection, myofascial pain, and hematoma. And finally, late local complication is alveolar atrophy, and a distant late complication is osteomyelitis and actinomycosis. Okay, so we could talk about any of that complication, but it's not so interesting, right? Let's move to oral enteral
Now you
communication
can
is the
hear me,
most
sir?
dangerous and most problematic one when we have
Sir, you can hear
removal
me?
of maxillary molars occasionally. Yeah, it could result in communication between the oral cavity and the maxillary sinus. Not good situation. So you have to know how to manage that. So the first thing that we have to do is to examine, sorry, the tooth once it is removed. If a section of bone is adhered to the root ends of the tooth, the surgeon can be relatively certain that a communication between the sinus and mouth exists. That's a huge problem, as I said. If a small amount of bone or no bone adheres to the molars, a communication may exist anyway. To confirm the presence of a communication, the best technique is to use the nose blowing test. It's very simple to do, actually. You pinch in the nostrils together, yeah, these things. Occludes the patient nose, and the patient is asked to blow gently through the nose while the surgeon observes the area of the tooth extraction. If a communication exists, there will be a passage of air through the tooth sockets and bubbling of blood in the socket area. Nice picture. Yeah, that's absolutely really easy to do, even in any private clinics, so that's no problem. And I really recommend you to do that in any tooth extraction, even if you see the ultrasound tomogram and there is very everything, okay? That could be some problems. Because you remember, ultrasound tomogram is two-dimension picture of three-dimension space, so could be problems. After the diagnosis of oral communication has been established, the surgeon must determine the approximate size of the communication because the treatment will depend on the size of the opening. If the communication is small, we talk about 2 millimeters in diameter or less, no additional surgical treatment. If the communication is small, yeah, 2 millimeter in diameter or less, no additional surgical treatment is necessary. The surgeon should take measures to ensure the formation of the high quality blood clot in the socket and then advise the patient take sinus precautions to prevent dislocation of the blood clot. So the main thing here is that blood clot exists in there in our problem area. So that's the answer of all problems. So if you keep it, everything's gonna be okay. Sinus precautions are aimed and preventing increases or decreases in the maxillary sinus air pressure that would dissolve the clot. Patients should be advised to avoid blowing the nose, violent sneezing, sucking of straws, and smoking. Patients who make and who cannot stop, even temporarily, should be advised to smoke in small puffs, not in deep drugs, to avoid pressure changes. Okay, let it be. Here's more interesting, right? With picture. If the opening between the mouth and sinus is of moderate size, from 2 to 6 millimeters, additional measures should be taken to help ensure the maintenance of the blood clot in the area. A figure of 8 suture should be placed over the tooth socket. It's like on the picture, very easy to do. So you can do that with one needle, right? The patient should also be told to follow sinus precautions. Finally, the patient should be prescribed several medications to help lessen the probability that maxillary sinusitis, sorry, will occur. Antibiotics, of course, usually amoxicillin or clindamycin, it doesn't matter which one, should be prescribed for 5 days. In addition, decongestant nasal spray should be prescribed to shrink the nasal mucosa to keep the ostium of the sinus patient. As long as the ostium is patent and normal sinus drainage can occur, sinusitis and sinus infection are less likely. An oral decongestant is also sometimes recommended. If the sinus opening is large, and we talk about 7 millimeters or even more, the dentist or dental surgeon should consider closing the sinus communication with a flap procedure. This actually requires that the patient be referred to an oral and maxillofacial surgeon because flap development and closure of sinus opening are somewhat complex procedures that require skill and experience. Not sure about your country, but perhaps you can do that. That invasion being just dentichirurgien, perhaps not sure, you need to check it in your country because here it's possible because we're not dentist like you, okay? So need to check that information. The most commonly used flap is a buccal flap. The technique mobilized buccal soft tissue to cover the opening and provide full primary closure. This technique should be performed as soon as possible, preferably on the same day in which the opening occurred, of course, very logically, right? The same sinus precautions and medications are usually required. And another complication that we could have is post-extraction hemorrhage. After a routine extraction, it is expected that bleeding will cease after no more than 10 minutes. If bleeding continues, the area should be inspected for signs of mucosal tearing or the other evident cause for continued hemorrhage. In the absence of any such sign, a further period of 10 minutes with film pressure of the wound should be tried. Every effort should be made to determine whether the bleeding is arising from mucosa or bone. If tears in mucosa are found, they should be sutured. They can be remarkably difficult to find if they have occurred posteriorly, especially lingual to lower third molar or posteriority to maxillary third molar. Next things about suturing and hemorrhage. Of course, if you have a bleeding, you need to do suturing. Of course, it's absolutely understandable. If suturing alone is not successful, responsible hemostatic agent, it could be, for example, oxidized cellulose, fibrin foam, gelatin foam, collagen granules, and alginate fibers. So that agent, agent, is placed in the socket and the wound resutured. Usually, a bleeding socket responds to these measures. However, if bleeding continues, consideration should be given to the possibility of factors of a purely local minor problem. Bleeding of almost any cause can be arrested by packing the socket with gauze soaked in antiseptic varnish. This material slowly sets to film consistency over hour to days, and it will tolerate it against bone. It does not become full for a matter of weeks, so can be left in place for some time if necessary. Because of its consistency, the dressing can be compressed into the socket and secured readily with sutures. However, it should be removed normally at about 1 week or even two. It depends. Okay, it depends. And as summary of any complications, prevention of those complications should be a major goal of the surgeon. Skillful management of complications when they do occur in the sine qua non of the wise and mature surgeon. The surgeon who anticipates a high probability of an unusual specific complication should inform the patient and explain the anticipated management and sequelae. Notation of this should be made in the informed consent that the patient signed. General complications which occur after tooth extraction could be myocardial infarction, stroke, and subcutaneous emphysema in cheek, neck, or chest. Could be brace of sclera, it could be hysteria and traumatic delirium, hyperthermia, and cavernous sinus thrombosis. The last topic of that lecture is about atypical tooth extraction. An atypical tooth extraction, that's a method of exodontias which is performed with chisel and bore. So it happened when you cannot remove or extract that tooth with forceps, okay? So it's not possible to do. Most cases is impacted tooth. So it's indicated when tooth and root extraction cannot be performed with a dental fouillère, as I said, okay, or elevatos only. This method most frequently is used to extract third lower molar. The surgical approach and direction of the incision depends on tooth and root position. Access to the tooth is achieved by forming and raising a mucoperiosteal flap. Then using bore and chisel remove portions of bone that covers the tooth. Exposed tooth can be removed. Sharp bone edges should be smoothed. The flap is returned on its place. The surgical or atypical teeth extraction, including next stages: raising the flap, removal of bone, tooth division, removal of tooth or tooth fragments, and primary closure. Yeah, it's a different ways how they could look. I mean, we talking about the third molars and their position in the jaws. And There is of course, there is some other tooth that could be impacted, but third molar is more common for that. So it could be canine, actually, very often too. But canine, they try to reposition it to the dental arch using some orthodontic techniques. So, mm, if it possible, do not remove the wisdom tooth. Not sorry, do not remove the canine because it could be in his position, in normal position, as a result of orthodontic treatment, of course. Yeah, so even if tooth is his normal position, but still under the bone, we need to do the atypical tooth extraction. So any tooth extraction that is not using with forceps, it's very easy to do with those 5 steps as we talked previously. So you need to remove it using the typical methods of tooth extraction. Um, a typical instruction leaflet given to patients after extraction. Of course, you need to say those things just to reduce till the zero your consequence of after tooth extraction. If patient will do all that things, the risk of any complications are minimum.